All right, burns. Before we get into our heavy burn content, let's talk about the classification of burns. Burns can be superficial or first degree. They can be partial thickness or second degree. They can be full thickness or third degree. They can also be fourth degree. Superficial first degree burns, think of like your sunburn. They're minor, painful. They typically heal without scarring in 3 to 5 days. I know that there are definitely more severe sunburns out there, but we're kind of thinking of the minor sunburn that we get and the one that's extremely painful. The next is the second degree burning or partial thickness. This is what we get from a flame flash or a scald. They typically heal in 14 to 28 days with variable amounts of scarring. Third degree or full thickness burns. These are our burns with serious injuries. Nerve endings are destroyed. This is what you receive when you come into contact with fire or contact with hot objects. If our patients would have fourth degree burns, these burns can extend into the fascia, muscle, and bone. These are the burns that require surgical excision of eschar, and we're typically placing grafts. Classifications of burns are based on a few different things. We look at the extent of the burn, determining surface areas of burns, and how children differ from adults. There is a chart in the burn chapter that you guys took home. You won't need to worry about calculating body surface area of burns though, but just take a look at the chart so you kind of understand what we're talking about there. There are some risk factors for burn injuries when it comes to our kids. Electrical outlets, kids, especially infants who are crawling around, toddlers, they are interested in those, like to play with them, so make sure we are baby proofing those. Our thermal burns, again, our flames, our hot surfaces, our hot liquids. Make sure, if we can, use the back burners of our stove. Keep hot liquids off the edge of the counter so the kids can't reach up and pull them off on the counter onto themselves. Chemical burns, again, keep chemicals locked up. Lack of supervision and developmental level of the child is really one of the biggest risk factors for burn injuries in kids. Burns, child abuse, 10 to 20% of the burn cases that we see are because of abuse. And also, we've talked about this, I believe, in one of our first 2 lectures about how kids are interested in fire. And 1 in 10 house fires start because kids were playing with fire. Immediate care of the burn. I believe there is a chart in the chapter. Make sure you're taking a look at that. The first thing we need to do is stop the burning process. Hopefully we can smother the burnout, kind of think your stop, drop, and roll. You want to check your ABCs. Do they have an airway? Are they breathing? How's their circulation? You want to remove the burn clothing and jewelry. You want to cover the burn to prevent contamination and infection. You want to make sure we're keeping them warm. We want to transport for medical aid. We're doing IV and O2 therapy at this point. We'll keep them NPO if it's an extensive burn, and make sure we're reassuring the child and the family, keeping everybody calm in this situation. There are a few things to think about when we are calculating the extent of the burn injury, in addition to body surface area. The type of the burning agent, so what caused the burn, the duration of contact, how long were they in contact with those items, and the area of the body in which the burn occurred. The higher up on the torso, face, neck, we're really worried about airway. These are our problems that we're going to talk about: airway, risk for imbalanced fluid volume, imbalanced nutrition, acute pain, management of the burn wound, which has some subcategories that I'll talk about, and then also prevention of complications that have subcategories as well. So again, with any burn, we need to figure out, was it intentional or unintentional? Make sure we're getting a history that's compatible with the child's age and their developmental level. Once we kind of got all of that taken care of, airway maintenance is your first priority. You need to assess any respiratory involvement. Did the fire, the burning take place in an enclosed space? You're thinking smoke inhalation. Is there any obvious edema to the oral and nasal airways? Again, I talked about, was the injury closer to the face, the upper torso? If we suspect respiratory involvement, we need to give 100% O2 and make sure we're checking blood gases. Again, when these kids come in, their airway may be fine at first, but we need to closely monitor that airway again if they had any of those risk factors. If we're worried about smoke inhalation, and if the burn was close to the face or the upper torso, because that airway, the edema can come later to those areas. So always make sure we're assessing that, and make sure you're looking for signs and symptoms of airway obstruction, changes in sensorium, their LOC because they're not getting enough oxygen. Are they air hungry? It actually looks like they're gasping for air, trying to eat the air. Any signs or symptoms of respiratory distress? We talked about those with our respiratory lecture. If we see any of those things, the first thing we want to do is get them intubated. Controlled intubation is the goal here if there is any airway involvement. All right, I put these somewhat in your priority. Airway is obviously your first priority. Your second is risk for imbalanced fluid volume, for sure. That's your number 2. The other ones, definitely we can move things around in there, but we need to make sure 1 and 2 are taken care of. Oh, sorry, I forgot to click. We talked about our airway, signs and symptoms of airway distress, your nursing interventions to support the airway and the outcomes. Let's talk about risk for imbalanced fluid volume. And again, it would be fluid volume deficit. Like the slide says, fluid replacement the first 24 hours, that is one of your most important things that you need to do. Fluid replacement is needed here for tissue perfusion, and this is where we would want to do the 20 mLs per kg that we talked about with our math module. You'd want to use a crystalloid solution such as 0.9 and LR. Again, with burns, water and sodium are lost. So we need to reestablish that sodium balance. We need to restore circulating fluid so we have adequate perfusion. It corrects acidosis, and those fluids will improve renal function. Don't forget, we need to get perfusion to those end organs, and our kidneys are end organs. That's why we're always looking at our urine output. If we don't have any urine out, it's a good indicator that we don't have good perfusion and or good circulation, so those kidneys aren't being perfused. With the water and sodium being lost, with the sodium, we have a decrease in sodium, and we'll see third spacing going on with that. We'll talk about third spacing a little bit more when we get into our hypovolemic shock. After the first 24 hours, we switch over to a colloid solution such as albumin. Don't forget, albumin and or plasma help maintain the plasma volume. So we want to give them all of these fluids to replace what they've lost. And then we need to give them this colloid solution, either albumin or plasma, to keep the fluid where we want it. Again, we'll talk, fluid shifts from the intracellular to the intravascular to the interstitial spaces. That's what we're seeing with that third spacing. And we're seeing that third spacing because our sodium is decreasing. So we need to make sure we're getting all this fluid in, but they also need that other solution to make sure the fluid goes where we want it to. We don't just want to make our patients edematous. We want to get the fluid into the spaces where it needs to be. This fluid replacement, without it, it will lead to hypovolemic shock. Again, their volume is low. This is an immediate life-threatening situation where 20 to 30% of a total body surface area burn occurs. Don't forget your signs and symptoms of hypovolemic shock. Heart rate goes up, respiratory rate goes up, and the blood pressure goes down. Weak, thready, or absent pulses, prolonged cap refill, cool extremities. Remember, hypovolume, so the volume is staying at their core, so it's staying in their heart and lungs, and we're not having circulation anywhere else. So that's why we're seeing those changes. Again, we got to worry about our fluid and electrolytes being imbalanced here as well. So let's make sure we're taking a look at that. So fluids, electrolytes, we talked about sodium, and we're going to throw potassium in here in a minute. In the first 24 hours, we talked about the sodium being low. You could actually see the H and H go up in the first 24 hours. Again, because of this third spacing, we're giving them all of these fluids, and that leads to hemoconcentration. So just kind of stop for a minute and try and wrap your head around what's going on with the fluids in those first 24 hours. And what we do after the first 24 hours is up to keep the fluids, okay? So those are some of our signs and symptoms that we're looking for in your nursing interventions, obviously, is to administer the replacement fluids. You would more than likely, in this case, insert a Foley catheter. We're checking vital signs, we're checking weight, we're checking I&O, we're checking urine output, your assessment, what's their orientation, what's their cap refill like, how are their pulses, what's the temperature of their extremities. We want to make sure we're taking a look at our labs. We already talked about sodium, we talked about ABGs. We want to take a look at our potassium. It could be high due to cellular destruction. When they come in contact with that burning object, cells are being destroyed, so that those cells will release potassium. Remember, we talked about dehydration, so what's going on with the BUN and the creat. Again, if the kidneys aren't being perfused, is there any nephron damage? If there is, we'll see an elevation in our creat. We want to look at our serum protein. Remember, we talked about giving them that albumin. So the albumin there is to keep the fluids in the spaces that we want, but don't forget about albumin. It's necessary for healing and maintaining our serum osmolarity as well. So we need good albumin, that protein, to heal. Another thing that we can check is myoglobinuria. It's a byproduct of muscle damage from the burn injury. So we can see a breakdown of that in the urine as well. We can elevate the limbs to promote venous return. Don't forget, we're giving them all of that fluid. We could cause some fluid overload and edema, so get those extremities elevated to promote that good venous return. And your outcome is that the child's well hydrated. How do you know that the child's well hydrated? Their labs look good, their vital signs are normal, their weight is stabilizing, they have urine output, their assessment, they're oriented, they have good cap refill, pulses are present, extremities are warm. So those are the things that we can look at. I'm not sure if I mentioned glucose. As a lab to monitor, I feel like I started out with potassium, but glucose, we want to monitor that as well. And we're worried about hypoglycemia, secondary to the burn stressor on the body. So make sure you're taking a look at that lab.